I do want to say welcome, good morning, good afternoon. My name is Kim Hansen, and I am the president with the Bloomington Chamber of Commerce. I've been on board for about 2 months, and I've come to this event for the first time, but I see wonderful familiar faces. So thank you all for making me feel so welcome. I see wonderful familiar faces from my past employment as well, which is great. I just feel very at home here. So please continue to enjoy your lunch. We've got a nice program, and I just want to read a couple of remarks here as we get going. So first of all, when they said that we're going to have this beer event quarterly, as I'm getting trained in, and my eyes lit up, and I'm like, oh, that sounds great, beer. And then I learned a little bit more about it. It's still a wonderful event, but what a great way to put those 4 chambers together with Bloomington, Edina, Eden Prairie, and Richfield. I mean, we're the 494 corridor, and a lot of business gets done beyond our borders. And that's what's so important about having you all here today. I'm hoping that you're all meeting somebody new or reconnecting with someone that you've wanted to see for a long time. That's what these are all about. So on behalf of B.E.E.R, these chambers represented here today, I do want to welcome you because, like I said, business really has no boundaries. And we hold these multi-level chambers, these multi-chambers events about 4 times a year, I believe. We're going to have a planning meeting here coming up in a couple weeks, so I'll learn a lot more. But this is a chance to expand your network, to, like I said, reconnect with folks that maybe you haven't seen for a while. Who here is brand new to the B.E.E.R event today? So I'm not the only one. Oh, great. So hopefully our fantastic topic got you here. Or did you really think there was beer involved? Anybody? Sorry. Maybe afterward, if you don't have anything the rest of the day, feel free. I also would like to take this opportunity to mention a brand new initiative that the Bloomington and Minneapolis Regional Chamber has unveiled. And it ties in nicely with Donna Zimmerman today and HealthPartners. This is something we've rolled out called MSP Wellness. And it's a workplace wellness initiative to help organize and create a plan at your offices, in your environments, and some policy changes that you can employ at your workplace to create healthier employees. You're going to have more productivity. You're just going to have a better work environment. And that's something that we're working very closely with the City of Minneapolis and the State of Minnesota on. So for more information, please go to our website. There'll be a link for mspwellness.com. And at this point, I'd like to introduce Ann Schultz, the president with the Richfield Chamber of Commerce. Ann and I had lunch not too long ago, so she could get my feet wet and all of this stuff. So thank you so much for being here and representing Richfield, Ann.
Thank you. Thank you very much, Kim, and welcome to your new chamber world. We are thrilled to have you and very excited that I'm now not the new girl. I would like to first take this opportunity today to recognize our host, the Sheraton Bloomington. I would also like to take a moment to acknowledge our B.E.E.R event sponsors. Without their support, none of this would be possible. We'd all be at our desks eating a turkey sandwich, and this is way better. So thank you to Centerpoint Energy, Choices Psychotherapy, Insperity, One Source, the Background Check Company, Promotion Select, RBCU, and Stone and Johnson. Thank you very much for being here today and supporting us with your dollars. And as everybody knows, when you are a sponsor, it is important for you to talk to everybody in the room. So please, if you did not stop by their tables before this, on your way out, take a chance and learn more about these companies by saying hello. Before I pass the mic off to Erica, I do want to say another special hello to the Eden Prairie High School members that are here today. I saw all these new, fantastic young faces walking in, and I thought, wow. And then they introduced themselves. They all walked up, said hello, and I just want to say it's really brave of you guys to come to a meeting like this and put yourself out there and learn something new, so congratulations to you guys. And at this time, I'd like to pass the mic to Erica, the Director of Operations for the Edina Chamber of Commerce.
Did you notice that Anne's wearing green? Just wanted to point that out. Well, good morning. It's actually afternoon now. I'm honored to introduce our keynote speaker this morning. Donna Zimmerman is the Senior Vice President of Government and Community Relations for HealthPartners. HealthPartners provides healthcare coverage to 1.5 million members and healthcare services for more than 1 million patients each year. She is responsible for state and federal public policy and community affairs across the organizations. Donna collaborates with community partners to improve population health in children's health, mental health, and health equity. She works in all areas of government and health reform product strategy and regulatory relationships, including Medicare, Medicaid, and individual products. Donna also represents HealthPartners with state and national trade association appointments and committees. Please join me in welcoming Donna Zimmerman.
Well, thank you very much for having me today. The timing is really interesting for us, and I'm very, very excited to be here. I also wanted to just acknowledge that I have my wonderful colleagues, Stephanie Frost, Bob Murphy, and Robert Freeman, who you all know, here with me today as well. So happy to have them join in on our conversation as we get maybe more into some of your questions that you might have. So I thought it would be fun to take you through just a little bit of what the political climate that we're working in right now related to healthcare and the Affordable Care Act. I did actually really like my earlier view of this slide had B.E.E.R on it, because it seemed like that went really well with healthcare essentials, but because, you know, some amount of B.E.E.R is probably quite good for our health. But at any rate, to talk a little bit about that climate, give you a little sense of the dilemma and some of the work that we're doing in the healthcare system to innovate and move forward amid the political climate and what's happening in the government side of healthcare. And then talk about some of the opportunities that we have together working with you, and we do work with many of you, and particularly the cities and school districts in this area, as your 494 partners, on some of the ways that we can actually help support the health of the whole community, which is, you know, again, where we think a lot of the action is. But first of all, so just for a little fun, actually I asked our team, we were talking with our senior staff today about the political climate in healthcare, and so I asked, well, could I get just some of the newspaper headlines on healthcare, and let's just put them up and have a little discussion about it. And it was so funny. It was like there was nothing that was remotely appropriate enough for a business audience on healthcare to stick up on a slide. So I found my own on the CBS website yesterday, and you know, I think it just it's not surprising, but it's kind of amusing to us sometimes how there's never any good stories in healthcare, in spite of the fact that we actually have a lot of good things going on in our state. We can't get media usually to report on them, but some of the funny headlines yesterday: researchers move closer to peanut allergy cure. How fat is your state? There was another one on an 84-year-old doctor that can't practice because she can't use a computer, and then contaminated cow's milk across 4 states. Those were some of the only headlines that I thought might be of interest to put out there, because there was frankly nothing else very good news for us to talk about. And the other thing I thought that might be fun is we like to do quizzes and things at some of our staff meetings at HealthPartners, and so there were a couple of polls out this week and last week on the Affordable Care Act. And of course, for those of us who are in the health policy world and policy wonks, we love to follow public opinion polls. So just shout out how many, tell me what you think in terms of this. What percent of the American public today approve of the Affordable Care Act? Now, there's two different polls. There's a Gallup and a Kaiser Foundation poll. So what percent of the American public do you think today approved of the Affordable Care Act? 70%, I heard? 65%. Okay. Anything else? 35%. Yeah, so what's so interesting about it is that this answer hasn't changed since 2010. It's about 50%. So there's about a 50% approval rate, some that has flipped up and down, about a 46% disapproval rate. Generally, people leaning Republican will be on that disapproval side. People leaning Democratic will be on that approval side. But and then there's always a bunch of people in the middle who don't even know really what we mean when we say the Affordable Care Act. So so it's not surprising, but it is very interesting that even all of the publicity that it has received through the years, good and bad, and for those of us who are steeped in it deeply, day to day, that it really has not, public opinion hasn't shifted a lot on the bill. And it really is kind of why we are where we are, and very difficult to move things forward to fix things that are wrong, because public opinion it's just half and half. And so here's the second question, and then I'll have one more at the end. But so the second question is, what percent of the American people feel that the current administration is going to be responsible to fix it? What percent do you think? 30? Well, interestingly, and maybe not so fun for those who are currently in elected positions, over 60% now believe that the current administration will be responsible for solving any of the problems that we currently have in healthcare and with the Affordable Care Act. So that's kind of a daunting situation if you're an elected official today, because as we know, it's pretty difficult to move legislation when you have this 50-50 deal about whether or not the Affordable Care Act is a good thing or not. So we're going to unpack a little bit of what's happening with that, and some of where we see and hope some changes could occur. You know a little bit about HealthPartners. How many of you are HealthPartners members? Yay, lots of you. That's awesome. We're the only organization in this region that is both integrated for financing and for care. That's a legacy that we have that goes back to 1957. And so we're really proud of that. We've obviously grown. We're lots bigger than we were in 1957. Some of our stats were already mentioned, but we're now 25,000 employees in this region, so it's very exciting to us. We are continuing to grow. One of the biggest combinations we had was back in 2013 when HealthPartners and Park Nicollet came together. Next year, Hutchinson Health will be joining our organization, and we're expanding into North and South Dakota with Medicare and commercial plans and some additional Medicare programming in Wisconsin next year as well. So it's exciting for us. We're growing as a care system, and we're growing as a health plan. Our mission, of course, and we'll kind of explain why, I think, as we go through the presentation, but it's really about improving health and well-being. I think as we talk about our mission with our colleagues, that word well-being is really important. You all were just talking about the importance of wellness programs. And it's just an acknowledgement that for us, we think that health is a lot more than just our physical health. It's also related to how well we feel about how our lives are going, that life satisfaction, finances, many other things come into play in terms of our overall well-being. And our programs and services are really designed to try to improve and impact all areas of health, and we'll talk a little bit more about that. So where are we in Minnesota? We actually have pretty good news most of the time. This is sometimes what doesn't get reported. in almost any ranking of health and well-being, if you look at different indices that are published in this territory, our overall ranking is usually 1 or 2 in the country. Now, this was the result of some work that the Minnesota Business Partnership did a couple of years ago with McKinsey, where they looked at different health statistics and different outcomes and claims and things like that from organizations all over the country, and things that were reported through the federal and state governments, and really came up with us as an overall ranking of 1. We were number 1 in coverage and access, largely due to our legacy of really having a lot of strong public support for health coverage in the way of medical assistance in our Minnesota Care program, and our uninsured rate. Particularly after, we were already pretty good before the Affordable Care Act. We were at about 92%. We went up to about 96% with the Affordable Care Act in 2014. So we're very, very high on that and have traditionally been national leaders in that. Population health, really if you look at anything like biking or obesity rates or things like that, we stand very high in rankings. So overall, a ranking of population health of number 2, healthcare delivery number 4 in state rankings. Again, when you combine all of these things together, it starts to paint the picture that things in Minnesota are going actually very well for the most part. And we should be proud of that. It also costs something. So I think the interesting thing that the business partnership found was that, in fact, being really high in quality and having a lot of access, it's a great thing, but it does cost something to be in that level of ranking. And so we are about average on cost for commercial, for employer-sponsored insurance. We are a great deal for the federal government and the state government, and we're about average in cost for commercial payers. And that's again, not a surprise. And then the actual cost of care overall in the state with our strong programs and our strong public health system bring that cost up a little higher. So what are the challenges that we have in healthcare? Well, we've got a lot of them. In some ways, it's kind of hard to, we don't want to spend the whole day talking about all of the different challenges. But really, I would say that in any analysis of health reform or programs, or even how we look at planning our products and our strategies for how we offer to you all as employers, it's really, really focused. Our challenges are in sort of 3 main areas. Affordability, probably, tantamount to pretty much everything we're talking about. Coverage and access, a challenge of how do we pay for it as a state, how do we pay for it at the national level, and then improving care. These 3 things are really the things that we care about and that we work on every day. So, the punchline for us is really, regardless of what happens with state and federal regulations and whatever happens to the Affordable Care Act and that half of the people like it and half don't, we are going to be focused and have been focused in trying to manage these 3 areas to provide the best care, the best experience for our members and our patients at an affordable cost. So that is really the framework around, I think the way all of us probably look at healthcare challenges is that they fall into these different areas. So if we look at proposals like the Affordable Care Act, how did that perform? We've had the Affordable Care Act with us now for many years. Actually, that time has flown. When we were planning for 2014, back in 2010, we thought, oh, that's a ways off, and all of a sudden it was here, and here we are about to enter 2018. And so we've been in this now for many years, and we've gathered a fair amount of experience in this new world. And I think the bottom line that we all need to remember about the Affordable Care Act is that it was really all about expanding coverage. And it was more about expanding coverage for people who are enrolled in our public programs for medical assistance. In our case, we have also Minnesota Care. And trying to provide more options for people who are purchasing as individuals. That's why they created exchanges. The exchanges were going to be a new marketplace for people who purchase on their own. There was thought that the marketplaces would work for small employers and that there would be, a new place to shop and new options out there and more competition by virtue of having exchanges. So as we looked at the Affordable Care Act, and again in Minnesota we already had about 92% of our state population covered in programs, the actual benefit to Minnesota was less than it was in Texas or Louisiana or Mississippi, where coverage rates are quite a bit lower. So what did happen is that a lot more people did get coverage. It was largely done through expanding the medical assistance program. We did that here as well in Minnesota. The Affordable Care Act also came with a lot of taxes and assessments to pay for it, to pay for that extra coverage. Some of that was levied on a smaller part of the market, fully insured small employers and individuals to pay for expanded coverage. That's some of the challenges, of course, that we're facing today as we move into 2018. But overall, the Affordable Care Act, probably its biggest drawback is that it didn't really address the underlying affordability of care. If we think about that, most of the healthcare dollar, in our case, our administrative costs at HealthPartners are about 6%. The rest of the dollars are going to pay for care and to improve quality. And so in that arena, we know that that underlying cost of healthcare is where all the action really needs to be. We need to be focused on improving and innovating in that care space. And that's hard to do in a regulatory framework. There isn't a lot of stuff you can regulate to actually make care better. A lot of that is happening with innovation in our clinics and in our health systems as we're working to be the best we can be. So that's why the Affordable Care Act, even though it's named that, was really more about expanding coverage. And it was a very important coverage expansion when we look at the country as a whole. But again, not so much on the affordable side. A little bit of work in there in Medicare to begin to pay more for value, which we fully support and advocate for in Minnesota, but not a lot of other things that really tackles that underlying cost of care. So if we fast forward a little bit so where's the debate today? We all know that there were a number of things that got debated last summer. There was a lot of discussion about whether the Affordable Care Act would actually get repealed in 2017, and numerous bills that Stephanie, our dear Stephanie, painstakingly went through for all of us in terms of what it meant, what it could mean. There was sort of a different bill a week about how the Affordable Care Act was going to change. But if you want to say, so really what has happened with the debate on this, I think one important thing to remember is that for the most part, for large employers and for Medicare, which are a lot of people across the country, majority of people getting coverage in one of those programs, there wasn't a whole lot about the Affordable Care Act that impacted those segments of customers or patients. And of course, that discussion is largely set aside today as well. So Medicare Advantage programs, Medicare cost plans from the health plan side, but even Medicare entitlement overall. Not much discussion about that, even though it's, of course, the largest area of government spending. And then employer market, not much on discussion there. On the individual market, of course, the focus was on how do we roll back all of the regulations around the individual market to try to make it more affordable, and what should we do? And so many of the early discussions on repeal were focused on how do we send that work back to the states? Let's just let the states figure this out. They worked it out before, let's let the states figure it out. And of course, that doesn't work real well when you still have a federal framework of laws in place. So for instance, in Minnesota, we had a high-risk pool. It was the largest in the country, pre-Affordable Care Act era that covered about 27,000 people with chronic conditions, and we can't have that anymore. You can't have a high-risk pool. So it wasn't as easy as just saying, go back to Minnesota and you guys figure it all out. But that has largely been the discussion around that, return authority to the states. There also has been a mixed review by our folks in Congress about how much should we really try to fix the Affordable Care Act versus getting rid of it. And when is that tide going to shift to, are we going to get rid of it, or are we going to fix it? And so I think for most of us working in the industry, the latter part of the summer, it was frustrating not to see certain parts of the Affordable Care Act get fixed that we think would actually stabilize the market more, because they were looking at the big law, getting rid of the large law. And then lastly, I think the discussion around Medicaid's been really, really interesting. I've worked a lot of my career around programs and products for people who are low income. And Medicaid has been, of course, a target and an area that is, in fact, in need of a lot of reform. It's not on a sustainable course for the states or the federal government, and a lot of work needs to be done there. But I do think that the discussion around the importance of the program came to light a lot more when Medicaid reform got wrapped into Affordable Care Act reform. So during the summer, there was a lot of discussion around, oh my goodness, if we actually eliminate all that Medicaid expansion that occurred in 2014, there are going to be a lot of people who lose coverage, and a lot of people who are on Medicaid are extremely low income. They might be elderly and low income, but have a lot of chronic health problems and a lot of other social conditions that create a very difficult situation to be thinking about pulling insurance coverage away from that population. So I think Medicaid has turned into a rather important discussion. How it goes forward, I think, will happen separate from what we do with the insured marketplace. But it is not an easy task to reform Medicaid. There are a number of organizations in our state, largely our delivery systems in the health plans, working through one of our not-for-profits here called the Institute for Clinical Systems Improvement, to look at Medicaid more holistically. So we're actually getting a McKinsey study done of the Medicaid program. How do we benchmark in this very large program against other states? Are we getting the value that we should be? But in my view, it should be set aside from the rest of what we're trying to do on the Affordable Care Act, and looked at, again, very, very carefully in terms of the impact on vulnerable populations. So the latest on reform, it's interesting. I mentioned the fact that we have the repeal and replace really didn't work. There was, however, some bipartisan agreement in the Senate. The Alexander Murray bill that was crafted actually did contain some things that would have been helpful to the industry and to all of us in terms of stabilizing the individual market and probably somewhat the small group market as well. That was, of course, didn't pass either, but some of the concepts that were in that stabilization bill are now being talked about in the context of the tax reform bill. So I'm sure that you're all following that tax reform bill pretty closely, and there are a couple of provisions we can talk about that are in there and that may actually happen in the month of December as we move forward. I think that the other part of that is that outside of the tax bill, there have been a number of things that the administration has done to try to address some of the issues with the Affordable Care Act. And while that's sometimes welcome news to us that you can circumvent the legislative process to do so, it's also a little bit scary because there's not much discussion or analysis of what the impact of that will be. So some of what we've seen come out in the regulatory process since the bipartisan measures did not pass in the fall were things like the ability for association health plans to form. That's something now that is out there. They're doing rulemaking around the ability to have short-term plans for up to a year That's in the rulemaking. Other features in that executive order from the Trump administration to try to address some of the things that have not worked very well in the Affordable Care Act. But by and large, these things they're better to happen in the legislative arena, but we don't see that happening anytime soon, and I think that we can expect that in the future we're going to see more things done, stretched as much as possible through the regulatory and the administrative process than the legislative process. I would have to say on Medicare, similar to Medicaid, but the idea of Medicare reform, this is usually taken on by a legislator at their own political peril. So we actually don't see a lot happening on Medicare. The days of what we might call grand bargains, or we're going to do means testing differently, or we're going to drastically alter the Medicare Part B program, which are doctors' services, or seniors are going to pay lots more. Those really big grand bargains are just so difficult to accomplish politically that we typically use a kick the can down the road approach with them. The administration also, I mentioned that in the Affordable Care Act and through some other legislation that was passed in addition to the Affordable Care Act, had really started to move the Medicare program in a direction that we support, which is paying for value versus the volume of services. So Medicare trying to do things that we're doing actually more in the private market to begin to pay for health care based more on quality and the experience of patients than it is simply how many you do. So one of the, I guess simply put, the way the Medicare funding formula happened really hurts us in Minnesota because we are a low-cost state for Medicare and very high quality for Medicare. If you're a senior or moving into Medicare, Minnesota is one of the very best places you can live. Diabetes care here in Minnesota is probably the best you can get anywhere in the country. And it's largely because we have organized medical groups that are integrated from primary to specialty care. Even if we think we have problems sort of coordinating care, it's just so much better than most parts of the country. Medicare doesn't reward that as much. Medicare set its fee schedule in place back in the 60s based on largely the volume of services. So if you did lots of tests, you were rewarded for that. So Medicare spending varies a lot on a beneficiary level basis around the country, and Minnesota's is relatively low. For us, that's good. We're getting better care, but in terms of fairness for products and services, not so much. Seniors in Texas get a lot more, and seniors in Dade County, Miami get the most. So that it's almost double what it costs to provide care here in the Twin Cities area. So again, paying for value is really important. And the other thing that's important here in Minnesota, one of the issues we're working on right now is we have Medicare cost plans in Minnesota, and they have been working alongside Medicare Advantage plans, and there are about 400,000 seniors in those plans. So we've been working with our delegation on continuing to offer those plans alongside Medicare Advantage plans so seniors don't have to change plans because that's going to be a big, big issue coming up in 2019. So we have some public policy on the health plan side, but we're also really, really pushing, let's keep moving quickly on paying for value. You just can't leave a policy discussion without at least bringing up drugs. And of course, there's no silver bullet here, but just to note that we now pay more for prescription drugs than we do hospital care. And that is, the drug manufacturers have made the headlines in 2017, certainly did in 2016 as well. If any of you attended our purchasers symposium, you heard something about that as well. But prescription drug costs are really the only unregulated part of the healthcare industry. They're regulated in terms of when new drugs are released, are they safe? Yes. Are they as effective as the drugs before them, they really don't have to prove that. So the bar for getting drugs out is really about safety, and there really aren't any requirements around, gee, how much did it cost to make that drug, and is your price reasonable as it's come to market? So very little consensus. Most of Capitol Hill in Washington really is interested in what pharma has to say. That is a very extremely strong lobby, and it is a part of Medicare, the only part of Medicare spending that is not negotiated. So we've worked a lot with Senator Klobuchar and Senator Franken over the past year on looking at different bills that they have put together to help address the cost of prescription drugs. Even in a highly regulated industry like ours, we'd say we need a little more regulation and it needs to be directed here. Partly to have, as new drugs are released, that they need to show not only are they safe, but they are as effective as drugs that were less expensive and issued before. So regulatory process might provide some opportunities for us, but this will be an area that's really important to watch, and public opinion is beginning to shift as well. There are more people now who are saying, you know what, Congress does need to do something about the cost of prescription drugs. Most people don't realize that it's actually fairly unregulated as it is. I'm going to just stop there for a second and just see if there's any questions on this area, and then I'm going to talk a little bit about some of how we view health reform and real reform as it happens within a delivery system in a health plan. Yeah.
And we just had a program at another meeting earlier this week on opioids, and how we consume, the U.S. consumes 99+% of the opioids manufactured. I think what I got out of that is that I think we maybe have to have a different thought on, can we go away with a little bit of pain? Do we have to be pain-free 100% of the time? So just some maybe reform there, and that might be a little more difficult to manage and figure out.
Right. Opioids as a subset of prescription drug issues has really risen to the top of a lot of interest, and most of the regulatory approaches have been to try to limit the supply by limiting prescribing practices or having doctors have to check registries for their patients who may have been on opioids. And then there's a large group of clinicians within our state who have been working on prescribing practices voluntarily, on really trying to substitute and start people on other anti-inflammatories. But yes, don't get people on in the first place, and use them judiciously, like after surgery. But there's a lot more that needs to happen in that arena on opioids, and it certainly does help. It is a cost driver as well, but there are obviously the other costs to the system by the addiction. Was there a question in the back there?
When you were talking, and I can't remember exactly what your words was, it was an outcome-based health care, maybe it was quality of care. How would you define that if that's how we wanted to pay on an outcome basis versus a quantity basis? What would be the criteria? How would you determine that?
Yeah, so that's just a terrific segue, actually. I am just like, we didn't even plan that. But so, you know, if we think about so real reform, how would we actually? We are all concerned about the cost of health care, right? So, you know, what kind of models? What should we do to help address that, as well as support actually improving health? So, you know, one of the big things is really changing the way we pay for care. And I mentioned that Medicare had made some strides along that way. We now have, and it's actually it's been adopted by our state government and a number of other states around the country. We developed a way of working with our healthcare providers. So as a health plan now, if you belong to HealthPartners, 80% of our members at HealthPartners now, it might be 90 by now, percent of our members who go to their clinics are going to clinics where their doctors are paid more for the quality of care and your experience with them than they are if they order you a bunch of tests. So it's a very different way of looking at how we pay for care, and we actually developed a measure on this that we got accredited by the National Quality Forum. It was the first measure of its kind in the country, developed at HealthPartners and accredited by the National Quality Forum, that looked at the cost of care as sort of a quality measure. So it combines the quality measure, and we know how we measure quality. There are standard ways of looking at, for instance, I mentioned diabetes. There's 5 different things that go into whether your diabetes is being managed effectively or not that lead to better health outcomes and lower costs. So we can measure your doctor and your clinic on how well they do on that, and it's publicly reported in Minnesota, which hardly happens anywhere because we have Minnesota community measurement here. So then we can turn around and pay clinics based on how well they're doing on care like that, how well your experience was, and we can tell them by the information that we can provide to them, oh my goodness, your results are the same as clinic next door, but your cost is that much higher. I mean, we were able to show them why. It could be that they're working with a specialty group that orders a bunch of tests, more than the specialty group over here that doesn't do that. So clinics are able to see, in looking at their total cost of care, why is it more expensive? If I'm getting the same results, why is it costing me 30% more than it is the clinic across town or the clinic group across town? And we're able to show them why, and sometimes it's just a matter of where they're referring their patients. Because if we look at the total cost of care, the pharmacy, the specialty costs, if there's any hospital care, primary care in that, physical therapy, all of those things, we're able to show, oh my goodness, you're more expensive because your orthopedic referral, they do tons of MRIs and they send them to places where they're very expensive. So that's how we start getting at how do we keep the quality high and start reducing the costs. And it's largely through providing good information, but it's also by measuring. So for us, at HealthPartners, we want to be 10% less than the statewide average for healthcare, and we're at about 9%. So if you come to a HealthPartners clinic, you're already getting that value of being highest quality, and we are 9% less than the market in terms of total cost of care of how we manage it. Yeah.
Hey Donna, that was a great overview of total cost of care. I just wanted to highlight it for you as well as everyone here that the new total cost of care report from Minnesota was actually published today.
It was.
It's in the Star Tribune, it's in the Pioneer Press. You guys can go online and read all of the detail.
It was on Minnesota Public Radio this morning. Yes. So.
It's in that report.
Yes, yeah. And we are lucky to have Minnesota Community Measurement to do that because we can go down and see how clinic systems perform on total cost of care. So really important. One thing about, I would just say as far as an example of that, we have a collaboration with Allina we call it our Northwest Alliance. This has been a long-term, multi-year collaboration. And I use it as an example because this is where we actually looked at a population of patients between Allina and HealthPartners in the northwest quadrant of the Twin Cities. So think sort of Mercy Hospital, Unity Hospital area, Coon Rapids, Blaine, Anoka, Andover area up in that expansion. And we've been able to reduce costs and improve quality by working on very specific clinical care programs with Allina for patients that are coming into our mutual clinics. Preventable readmissions, for instance, fell in this Northwest Alliance work that we've had by 25%, and that saves for every one of those, we can save about $13,000, every readmission in a hospital that we can prevent. So doing this work in a clinic system is really amazing, and if you look at the accomplishments there, if we look at where we were before and where we are now, healthcare costs have come down and quality has gone up in that area, and we're actually able to measure it by working together. So that's really exciting to us to have results like this where we can show that with concerted effort in a geography we can actually measure population health and we can measure our costs. And in this case, we're really happy with the results that we've had with working with Allina in this Northwest Alliance. The other thing that's important to think about is when we think about real reform is innovation. So, we have a couple of examples of, healthcare. For the most part, we work a lot to try to keep people from having to come into our clinics or our hospitals by having some alternatives. So worksite health is one example of that, as well as Virtuell. Has anyone here used Virtuell? Great. If you haven't, it's a 24/7 online clinic. It is done with our nurse practitioners. They treat more than 50 different common conditions. You can do the whole encounter from your phone and get a prescription, if you need one, sent to your pharmacy of choice. So think of an upper respiratory infection, or if you have pink eye or other minor illnesses, even contraceptive care can be done on Virtuell. Predictable price, it's $45 if you're just paying for the encounter, or if you, it can be billed to your insurance. So it really has been a wonderful program for us, and we have also shown that for every encounter that we have in Virtuell, it saves about $109, meaning that if someone didn't use Virtuell, they would have gone to an urgent care or to their clinic. So Virtuell is an important innovation in terms of care at the right time, the right place, and in this case you can get your care at home for certain conditions. Same with worksite health. The ROI on that, again, far better than having to come into your clinic. So worksite health is another innovation that we have done with many of our employer partners around the community, where you can again get minor illnesses treated at work, as well as health promotion programs. So before sort of this last section, just to talk a little bit about what really creates health. And I have to say that even as working for an organization that provides the full continuum of integrated care, we know that most care and most health outcomes are actually achieved by things that happen in the community. So the work that we do in terms of providing access to care, getting people into clinics for the right things, providing good quality care like diabetes care or heart care or preventive care, that only really accounts for about 20% of our health outcome. And so the rest of it are health behaviors, whether we smoke or our diet, alcohol use. It's social factors like income, education, whether we have a job or not, the kind of supports that we have, and how safe we are where we live. And then our physical environment in terms of quality and the built environment. Do we live in a place where we can walk and walk safely? So David Kindig at the University of Wisconsin Population Health Center really put this model together. This has been pretty much a platform for our strategic plan for health improvement, both for what we do in our clinics and also what we do in the community. And we know that we cannot impact health overall by only focused on one of these quadrants, because all of these things relate to health outcome. So that's sort of important to recognize. We also know, so when I said that Minnesota was one of the healthiest places, we also know that for many of our communities of color and for many health indicators, things like low birth weights for moms, rate of premature births, rates of diabetes, rates of cancer, all of those things are much worse in our populations of color. And Minnesota has some well-established statistics. You can find them at the Department of Health. You can find them on Minnesota Compass that shows really the differences and disparities. So we've been at this now for measuring health disparities at HealthPartners now since about 2006, and really making some nice strides in terms of improving things like mammography screening, diabetes care, colon rectal screening, and we know that there are things that we can do that help remove those gaps and create more health equity. And so this is kind of a fun slide, but it just shows the difference between equality and equity, and we actually know now that we need to do things differently and sometimes apply more resources for patients or populations that don't have them in order to achieve the same results. And so that's been a very important focus for us strategically throughout the organization. We also, and this is something we've done in many schools, we are active in about 60 public schools every year with a healthy eating program, our Power Up School Challenge. So this is, if any of your kids are in the school districts, you probably have come across this program, but we actually track kids eating. We do fun things. We come in with a pep fest, and then they do fruit and veggie tracking, all with the goal of getting 5 fruits and vegetables a day. Of all of those lifestyle indicators, that one is the toughest. That statistic for us is worse than smoking or alcohol use or physical activity even, is eating 5 fruits or vegetables a day. So, and important to start young. Mental health, super important, and we've worked a lot in the community around trying to reduce the stigma related to mental illness. Stigma is one of the problems that makes it for many people to not seek health care for mental illness for 8 to 10 years after, after symptoms. So decreasing stigma becomes really important, also providing very coordinated access in our system, and this is an area that we're all working to improve on, but we also think that there's a lot of work we need to do in the community around attitudes related to mental illness. So Make It Okay is our campaign. Right now we're doing a partnership with Minnesota Public Radio and John Moe's Hilarious World of Depression podcast. So check those out. Put them on your podcast list. They're really, really amazing stories of comedians and entertainers who have suffered from mental illness. And we use it as a way to open up conversations about mental illness. We also have a website with resources for you. Just yesterday, we had a wonderful program focused on early brain development for young kids. Super, super important, as most brain development happens in the first 3 months of life. So we're working with the Greater Twin Cities United Way, with Reach Out and Read Minnesota and other community partners to begin to bring up more of a public relations campaign and some targeted activity in different communities around getting the brain science into the hands of the parents so that we can all interact with the babies in our lives and improve brain development. It's going to be really fun. So we had 600 people in the room yesterday, and about 3,000 people watched it on TPT. So it's very exciting to us to think of a statewide collaborative. We would love to have you all involved in that as that rolls out in 2018. So, last but not least, so we talked a lot about how you innovate, how you improve health. What do you think the most important influencer of our health is?
Yes.
What was that? Attitudes.
Patient education.
What's that?
Patient education.
Patient education, yep. What else?
Focus on.
Yeah, our own focus on our health. Yeah, all super important.
Social connections.
Sleep, I like that one, yeah.
Social connections.
Social connections, yes, yes. So you all have just looked at that chart on the social determinants, and all of those things are more important, actually. It's kind of humbling, but in terms of our overall health than our clinical health. But the most significant indicator of what our future health will be is whether we've graduated from high school. And so this is why programs like working on early brain development or working in the community with children becomes very important for a healthcare organization, because we can work with others to impact high school graduation rates. It has a clear line of sight to better health. Better health is more affordable and better for all of us. So with that, I'll end my remarks, but just if we have time and you have any other questions, go for it. Anything else burning? Yes.
I want to go back to the cost of healthcare.
Yeah.
Does the federal government, when they calculate inflation, they take out food and energy, but is healthcare included as the government is looking at what the rate of inflation is, or is it on the side?
Yeah, so medical inflation, I would say that we all track, of course, medical inflation because the cost of health care is always higher than the rate of inflation. And so there have been various proposals, state government mostly, but about saying, well, let's just have health care be at the regular rate of inflation and not the medical rate of inflation. Now, things like prescription drugs just blows that out of the water. I mean, so that is, it's been more parsed out than looking overall at a rate of inflation but it is looked at in terms of overall spending. If you think about the trajectory that Medicare and Medicaid are on, there's various years where the Medicare Trust Fund, which pays for Medicare, is going to be out. That is based on inflationary factors in Medicare. Medicaid itself, the big debate around that was to put more risk back on the states and actually, instead of having kind of an open-ended Medicaid spending program, that they would actually block grant states based on the number of people on the program, and the states would have to manage those dollars, which of course most states do not want to do. But that's the thing that Medicaid will have to grapple with, is that it's not going to be an open checkbook, so we're going to have to figure out how do we make those programs work and how will they be sustainable over the long run. Yep, those are two big challenges because the rate of inflation is so much higher. Yes?
As a consumer, how do we go about finding the lowest cost for tests, like MRIs and X-rays and things like that? The cost seems to vary depending on where you go.
Yes, it does. And actually, the community measurement report has some information about that. I would definitely check that out. There are great differences in things like, particularly X-rays and MRIs and even laboratory tests. You can also go to our website, and we have a cost calculator out there. None of them are perfect, but we have a pretty good one that will help you estimate what your cost might be. And you can do some comparisons as well. We're getting better at it in terms of being able to show what you might be exposed to in terms of your own cost. But yes, there are shopping tools that you can use. Certainly check out ours. It's better. And then Community Measurements as well has done some nice work in that area. Well, thank you very much, and we look forward to working with you all. And if there's any follow-up questions, feel free to contact me or my esteemed colleagues here. You know how to find Robert as well. So thank you very much.